Welcome our dear friends, professors, colleagues, and fellows all over the world. Today is our first webinar through the Bifurcation campus. We started about 1 month ago. Our first webinar was Introduction to the World of Bifurcation, its classification, how to deal with algorithm, and etc. The second one was about our first technique, which was the provisional technique and the bailout techniques were explained in details. The second one, the third one was the T techniques. The fourth one was the crush techniques. And today we will discuss the Culotte technique. Actually, today we have two of the most eminent speakers, Professor Dr. Karim Mahmoud, lecturer of cardiology at Cairo University, and Dr. Muhammad Adel, lecturer of cardiology at Cairo University. We have also two of the most elegant and highly scientific professors in Egypt, Professor Dr. Tamer Mustafa, Professor of Cardiology at Zagazig University, and Professor Dr. Ahmed Shawqi, Professor of Cardiology at Ain Shams University. I will pass the mic now to my dear Professor, Dr. Tamer Mustafa, and we will listen to the first presentation from my dear friend, Dr. Karim Mahmoud. Please, the mic is with you.
بسم الله الرحمن الرحيم. اهلا بكم في السلسله التعليميه الجميله جدا في الانترفنشن. جروب very active very scientific، وان شاء الله السلسله الناجحه دي تكتمل بلقائنا النهارده. We have today the Cullotte technique. هيكلمنا ان شاء الله الدكتور كريم محمود، استاذ قلب في جامعه القاهره، عن الكالوت تكنيك. هل ستيل انه هو have a chance او have a large participation في البايفوركيشن تكنيكس ولا لا؟ هل انه المودرن ايرا بنقل استخدامها؟ هل في سبيشال سيتويشنز احنا بنفضل نستخدم الكالوت تكنيك؟ كل الاسئله دي واكتر ممكن نعرف اجابتها بعد ما يبتدي ان شاء الله دكتور كريم بتقديم محاضرته، وبعد كده هنبتدي بعض الدسكشنز المتعلقه والخاصه بذيس سبيشال تكنيك. هل هو ups or down؟ هل هو still preferred in special situations or not؟ كل ده هنعرفه بعد ما الدكتور كريم ان شاء الله يتفضل بإعطائنا محاضره من محاضراتكم الجميله، وان شاء الله تكون امسيه تعليميه في علم القسطره جميله ان شاء الله. اتفضل دكتور كريم باذن الله.
Thank you, Professor Dr. Tamer Mustafa, for joining us today and for moderating this session. Today, I'm going to discuss Culotte technique as one of two-stent bifurcation technique. So our agenda today will highlight three issues. The first issue is Culotte as a two-stent technique. The second issue is Culotte as a bailout technique. And the third part will be comparison of Culotte with other bifurcation technique. So every now and then we encounter this bifurcation lesion with a Medina classification class 111, meaning there is a significant stenosis in the main vessel, both proximal and distal, and in the side branch. And accordingly, we choose different technique according to each situation. I'm going today to discuss Culotte technique as a treatment for this type of lesion. So first, this is the ABC algorithm for treatment of bifurcation lesion. We'll talk about the two-stent technique. If we decided to do a two-stent technique for a bifurcation lesion, the first option is to start with a main vessel with the main stent across the side branch, as in the tab technique or in the Culotte technique. The other option is to do a stenting of the side branch, like a step or decay crush technique. And the third option is also like the first option, which is inverted Culotte or inverted tab, meaning that the stent will go into the main vessel and stenting the ostium of the side branch, then doing the dealing with the main branch as the side branch. So Culotte, in the Culotte technique, we can start with the main branch, or we can start with the side branch, according to the issues that we will discuss in the next slides. So, how to do a Culotte technique? Again, back to the Medina, the bifurcation lesion with the Medina classification 111. We will wire the both vessels. Then, very important step in every bifurcation strategy is to do a good pre-dilatation of both the main vessel and the side branch. So either to do it sequentially or to do a kissing balloon inflation for a preparation of the bifurcation lesion. Here we'll start with the side branch with the stent extending from the proximal main vessel into the side branch, then inflating the stent, the first stent into the side branch. There is a modification that was introduced in the past years, which is doing a several bot technique in the Culotte. So after deployment of the first side branch stent, we will do a first bot. Then this is the first rewiring with passing the wire into the main vessel and do a struts dilatation in the previously deployed stent. This is followed by, after dilatation, we introduce the second stent into the main vessel and doing the stent deployment. And here we obtain the two stents that have the pantalon shape or trousers or the Culotte shape. And this is the time for the second bot here after the deployment of the second stent. So this is the time for the second rewiring for doing the final kissing balloon inflation. And after doing the final kissing balloon inflation, we should do the third bot, and this will be the final result with the both stent deployed and opposed in the side branch and the distal main vessel. And after the bot, the double layer are well opposed in the proximal main vessel. And coming to the end of the first part, this is a video for how we did the Culotte technique. Here is the lesion, wiring the both vessel, preparation of the lesion, first stent, first bot, and wiring, then doing the stress dilatation, introducing the second stent, the second bot, then the second wiring, doing a stress dilatation again, the final kissing and the final bot to have this final result. So this is the end of the bot at two stent technique. And I'd like to hear the comments from our dear professor, Dr. Tamer Mustafa. So I think maybe we should continue. We in the first part of this.
Okay, Karim, you hear me now? Okay.
Yes. Yes.
Karim, I want to ask to you about what is the difference between the type of the lesion when you are choosing between a decay crush technique and the Culotte technique?
Thank you, Dr. Tamer, for this nice question. Actually, as we will mention, the Culotte technique need matching of the main vessel proximal, main vessel distal, and the side branch. So we should have appropriate diameter, or the diameter should be not mismatched between these three segments to do Culotte technique. Regarding which lesion or which technique to choose, I think this is the matter of testing and the matter of the studies. The bifurcation lesion 111 can be treated with either the crush technique, with the Culotte technique, and the tap technique. However, which technique should a better outcome? This is of course an ongoing research question. However, there is some trial that I will mention in the coming slides regarding which was preferred and which has a better outcome in the clinical trial.
Karim, I want to ask the same question, but by another way. When you choose, you prefer to choose Culotte technique. The size between side branch and main branch equal size. This is a preferring point, or other points to choose your default technique to start with Culotte technique.
We should have the diameter of the three segments to be mismatched. There should be no mismatch between the three diameters. This is the first part, first point to be mentioned to choose the Culotte technique. The second point, with the angle of bifurcation should be as small as possible, because with every increase in the angle of bifurcation, this leads to failure of and in-stent restenosis in the future with the Culotte technique. So, number one, a match between the three segments. Number two, a small angle of bifurcation should be present for the success of the Culotte technique. Number three, and I mentioned, I don't prefer to use a decay crush technique in the situation with the thrombus burden and the acute situation. This is my preference because the decay crush technique has some technical difficulties that can hinder the success of the procedure and hinder the speed of the procedure in the acute situation. So this is the additional point beside the technical point in the clinical situation of acute myocardial infarction and thrombus burden. Maybe I shift to a Culotte technique rather than the decay crush technique.
Karim, do you want to prefer to use a Culotte technique in the left main bifurcation or not?
This is a very good point also. The Culotte technique did better in the non-left main bifurcation. As we mentioned in the last webinar, the decay crush has the better outcome till now in the left main bifurcation based on decay crush 5 trial. However, in the trial that I will mention later, the Culotte technique was better in the left main bifurcation rather than the left main bifurcation. However, we might use a Culotte technique in the left main bifurcation if we have a side branch lesion that we should fix it with a stent that goes from the left main into the LCX. So in some situation, we use the Culotte technique in the left main bifurcation. However, the preferred based on the trial is a decay crush in the left main bifurcation.
Okay, Karim, the last question in this part, I want to ask, you are first putting your stent from your stent in the side branch, then you pass through the strata to put the stent in the main branch, okay? when you use the reverse of this?
Okay, this is also a very good question. So in the Culotte technique, we choose, let us forget about the main or side branch.
Yes.
We choose
Okay,
to
I
put the
agree.
stent in the more angulated vessel rather than to do the stenting of the straight vessel. So we will leave the wire in the straight vessel, the straight branch, and we will start stenting in the Culotte with the angulated vessel.
I do
This
agree.
will help this will make the procedure is easier, and will help to facilitate the rewiring into the both branches in the, because we need in the Culotte two rewiring, not just one rewiring
Yes.
as in the tab.
So I do agree again. So okay, let's move to the second part, Karim.
Okay, thank you so much, Dr. Tamer, for this nice discussion. And this is the second part, is a Culotte as a potential bailout strategy. If we have a, if we did a provisional stenting, which is the main bifurcation technique we did for the bifurcation lesion, and we encountered after that a severe pinching of the side branch, and we decided to fix this side branch. In some lesions, to treat this type of lesion, we can choose between the tab or Culotte, or maybe, of course, the kissing balloon inflation if we decided to do just balloon inflation. However, if we decided to put a stent, we will deal with this lesion by tab or Culotte technique. So if we have this type of lesion with a narrow angle of bifurcation, as seen here, if we use the tab, the stent, our stent may protrude into the main vessel, and this protrusion may partially obstruct the flow in the main branch stent. So in this situation, if we feel that the protrusion of the stent will be too much into the main vessel, we might use the Culotte technique, doing some overlap between the two stents. We should, of course, make this overlap short, but we can extend our or protrude our stent back to do a Culotte technique as a bailout technique in this provisional stenting. However, there is some points we should remember about both, as we mentioned. This is a very good trial that mentioned the predictor of Culotte failure. And the most significant predictor is increasing age. Regarding the angle, with increasing the bifurcation angle, this will lead to a more in-stent stenosis. Regarding the main vessels, increasing the stenosis in the distal main branch will also lead to the Culotte failure in the future. And the last point regarding the side branch, with the small reference diameter and side branch, and of course this is because the mismatch that will happen between the side branch and the main branch, this will also lead to the Culotte failure. So this is a 4-point, this is the most significant point regarding the predictor of the Culotte failure. And this is the second part. This is a short part regarding using a Culotte technique as a bailout strategy. So, Dr. Tamer, I'd like to hear your valuable.
كريم برضو يعني لو سألت if I want to ask about when this situation is compared with professional stenting, such a branch may be the size not equivalent to the main vessel. Okay, in this time, do you want to do a kissing balloon and to keep an option of putting reversed stent by crush or mini crush technique, rather than to put a Culotte technique, especially there's a difference between the size of the side branch and the main vessel?
Thank you, Dr. Tamer. Of course, if there is a mismatch between the side branch and the main branch, Culotte will not be an option because this will lead to this is will lead to a very much discrepancy between
Yes.
the size of the stent distal and the proximal, and it may lead to, if we decide to put a small stent and we did excessive balloon dilatation, we might lead to an stent fracture complication that we don't want to happen. So we should have a match, a relatively match between the side branch and the main branch to use the Culotte technique in this situation. Otherwise, we would use a kissing balloon inflation. We will try to use the tab. Of course, there is the technique that I hate, which is the internal crush. I don't like it so much. But in this situation, I think the best is using a kissing balloon inflation or doing a tab technique.
Karim, what is the optimal angle to do to go with this technique? The second point, what's the do you prefer, which angle do you prefer to go with this technique in the second situation?
If we look to the angle, the acute angle, it means that the angle is less than 70 degrees. And here, if we look to, this is the logistic regression model, with increase of the angle by 10 degrees, this will increase the odds of in-stent restenosis later. So the smaller the angle, below 70 degrees, the more likely that this procedure will be successful and the future outcome will be good. So I don't recommend to use this procedure if we have a wide angle more than 70 degree angle of bifurcation.
Karim, how the increasing age predicts the failure of Culotte technique? This is related to calcification or more rigidity in the vessels, or what?
Of course, so with increasing age, we encounter a more calcification and more fibrosis in the lesion, especially in the side branch lesion. If we didn't achieve a good pre-dilatation and adequate pre-dilatation of the side branch lesion with the presence of fibrosis and calcification, the incidence of failure of any bifurcation technique will be high. So the impact of age is the degree of atherosclerosis, the extent and degree of atherosclerosis, and the presence of calcification and fibrosis, as you mentioned, Dr.
Do you think that an IVUS will help you in this situation or not?
Of course, IVUS is helpful in every bifurcation situation.
Yes.
The IVUS will help as a preparatory for the bifurcation lesion, knowing the extent of the lesion, the reference diameter, and the normal vessel, normal reference area in the main branch and the side branch. And the IVUS will be helpful actually after deployment of the stent regarding confirming the adequate apposition of the both stents in the main branch and also in side branch, and especially in the side branch, which is the area of the increased in-stent restenosis, as will be mentioned in the later trials.
Okay, thank you, Karim. We can proceed for the third part, okay?
Okay, thank you, Dr. Tamer. And here is the last part of this introduction to the Culotte technique, which is a comparison with other techniques. There is a multiple trials that compare Culotte to the crush technique in general and Deke crush technique in specific. Back to 2009, the Culotte is still there is a trend that the Culotte will be better in comparison with the crush technique regarding the in-stent restenosis. However, with the introduction of the Deke crush with the Chinese group, the Deke crush showed a better survival and lower MACE as compared with Culotte. However, repeating these results in the Nordic trial showed there is a comparable result between the Culotte and the crush technique. So the Chinese group did this meta-analysis and showed that there is no significant difference actually between the Culotte and the crush. However, there is a trend that the crush may be better, mainly due to the result of the Deke crush 3. And this was for the target lesion revascularization and for the MACE. The most important point that was significant is the stent thrombosis. The stent thrombosis was better in the Dickey crush technique as compared with the Culotte technique, mainly due to the introduction of the Dickey crush technique. So the crush is comparable. The Dickey crush may be better than Culotte. However, when comparing the Culotte to the TAP technique in this nice trial, it showed that the main vessel, there is no significant difference regarding the incidence of in-stent restenosis. However, the incidence of in-stent restenosis was higher in the TAP technique, reaching 16.5% as compared with the Culotte technique, which is 6.5%. So this is a short comparison with the trials of the two-stent technique. And here I reach to the conclusion that we need to have a matching of the diameter of the main branch, proximal, distal, and side branch. We need a narrow angle of bifurcation for the success of this technique and the decreasing the future worse outcome. We should avoid much overlap of the double metal layer in the main proximal vessel. Three-step pot is introduced and is preferred now. And the Culotte can be used as a bailout technique in the provisional stenting. And we reviewed a comparison of the two stent technique, mainly Culotte versus the crush and the Culotte versus the TAP technique. And thank you so much. And back to Dr. Tamer.
Karim, thank you very much for this elegant presentation, and your steps is very clear. Especially, we need 3 steps put, and we need 2 rewiring. Remember that in this technique. Karim, in the rewiring. Okay, Karim, in the rewiring, there is a difference to go from a certain part of the strata, proximal or distal part, or the same. If you want to rewire your rewiring, there's difference to go from proximal one, distal one, mid one.
In the Culotte technique and in the usually in TAP technique and in the provisional stenting, we prefer to go into the distal struts. This will lead to a better scaffolding of the stent into the side branch. Here you can appreciate I try to demonstrate that the wire should go into as much distal strut as we can to do a better scaffolding of the main branch stent into the side branch and to get a better scaffolding of the side branch stent after the deployment of the side branch stent.
This is different from other techniques in bifurcation to go from proximal or distal stents.
Yes.
If we go for another for TAP for.
Yes, the TAP is also we should go through the distal struts. However, in the crush technique and the Dickey crush technique, we should try to go more proximal to a relatively more proximal struts, because this is again, as discussed in the last webinar, will ensure a better stent coverage after botting the main branch stent.
So we need the proximal one in Dickey crush and the distal one in the other tech. Okay.
Yes.
Okay, I agree.
Thank you, Dr. Tamer, and I go to. I'm going to show a case that I used a Culotte technique.
Karim, we have a question from the audience about the length of the segment overlapped between the two stents in the mother branch in the Culotte technique. Would you prefer a large segment of overlap or a smaller segment of overlap? And how much or how tall would you consider this segment?
Thank you, Mohammed. I prefer, as I mentioned, a short area of overlap between the two stents. This area should be as short as we can. I think it can be about 3 or 4 struts. This might be enough to do about 2 to 3 centimeter, 2 to 3 millimeter This would achieve a good overlap between the two stents, and this is will avoid the increase in the double metal layer that will lead to future in-stent restenosis and future in-stent thrombosis.
Thank you so much,
Karim.
Karim.
Okay.
You may continue
Karim, can
sharing
I have
the
a
slides
question
while Tamer
before going?
moderates.
Sure, Dr. Tamer.
Karim, if there is a high bifurcation between the D1 and the LED, so we have a short distance to do a pot. Okay, what will you how to proceed if there is a high origin of the diagonal, which is the culprit? So short distance between the proximal LED and left main. The shortest balloon cannot cover. It's not enough. It's longer. So what to do? What will you do?
This is a very difficult situation, Dr. Tamer, and thank you for asking. So we now have an area of proximal LED of about 3 or 4 millimeter. This is right. Dr. Tamer, you mean an area of a proximal LED of 3 or 4 millimeter. So the smallest balloon will be large for this area. I think you mean that, Dr. Tamer.
Yes, the shortest balloon will go inside the left main. So what will you do?
Okay. If I have actually a large left main, I might inflate the balloon in this a very short balloon. If we have a 5 millimeter balloon, I might inflate this short balloon to do a pot, but I would do one single pot. I will not do an excessive pot, and will do will be a final pot actually. So this is my opinion. It might be wrong, but I would be a single pot, provided that the diameter of a left main is large, to not cause a barotrauma by inflating the balloon that goes outside the stent in the proximal LED.
Could you proceed, Karim, to do Culotte technique without any pot?
In the previous era, we did that. Actually, we did that. However, based on the results of the clinical trial and the results that in-stent restenosis is seen lower with doing better pot, so I'd recommend to do a pot as much as we can, the 3-pot technique in every stent in this era. But in the last few years, and about if we back 3 or 4 years, I did that without pot actually.
Karim, if you cannot do a pot, you will change your technique or not? If I cannot do, I will change. Will you change your technique, or you continue with?
Actually, pot is an important step in every bifurcation technique. So we should finalize every bifurcation technique nowadays with pot. So I think pot won't affect the decision of the technique, but what we should do is doing pot at the final step for every bifurcation technique.
So if it is not visible clinically, you will change your technique or you will continue? It is not technically visible to do a pot in very short proximal LED or very short.
No, if I didn't do bot and I see that there is adequate opposition of my stent, so I will stop. But the most important that I have adequate opposition of the stent and I have a TIMI3 flow. If the bot is not feasible for any reason, I will stop.
Okay.
So
Karim, I want to ask the question of Dr. Tamer, Professor Dr. Tamer again, because it is a very important question. I think you couldn't get the question. The question, if we can't do bot because we have not enough length for bot.
Yes.
That's the Professor Dr. Tamer question. If we have 2 or 3 millimeters just before the bifurcation of LED diagonal, This bifurcation lesion is candidate for Culotte or whatever, but we only have 2 or 3 millimeters before the distal left main, for example. So,
Yes.
should we refer this patient to surgery, for example, because we can't do both, or can we do the technique, Culotte, or any other technique, any other bifurcation technique, if the both is not feasible?
Um, Thank you,
It's a question for
Abdurrahman.
Karim.
Thank you again, Abdurrahman. In my point of view, I don't think that the surgery is the matter of doing both or not. What I think, if we have and we should obtain an sufficient area for doing a both. If not, and we decided to do a bifurcation lesion 111, I want to add, I want to stress on the surgery. The surgery will have another criteria such as syntax score, such as the clinical criteria of the patient. But if the patient have a very proximal bifurcation lesion, which is the class 111, and a short segment with the bot, the bot is not feasible at all, I'll just do kissing balloon inflation with a short hanging balloon to obtain to get the better apposition of the stent. However, the pitfall here that our stent will be elliptical, not circular. What bot achieve is to correct the stent and make it circular. However, with the two stenting or short kissing balloon overlap, I'll get a better position. However, this will be the side of the shape of our proximal stent, which is we don't have an important data regarding the clinical impact of this spherical shape or elliptical shape. However, the spherical shape is preferred than the elliptical shape.
This is an excellent point, actually. And let's go back to the basics. I know what Abdurrahman and Dr. Tamer are pointing at. Like we have a very short distance in the LED before it gives the diagonal, and we have a 1-1-1 bifurcation. So actually, from the basics of the bifurcation, you will consider this two bifurcation with the atheroma extending beyond 5 millimeters. So actually, if you only have 3 millimeters, then you will do a left main LED stent and you will do the diagonal bifurcating with the LED. So in this case, you consider that the left main is the proximal extension of the LED, and you will deal with the left main LED together as the mother branch, as if it is the LED, and the diagonal is the side branch, and you will go on regardless the names. But you need, as Karim said, to put in consideration just the sizes and the proper apposition. The intravascular imaging will be of very good help to help you with the proper sizing of the LED versus the left main. So maybe there will be a discrepancy in the size. But as Karim said, as much as possible, whenever you do a kissing, and as we said previously, the kissing proximal dot of the kissing balloon is just at the ostium. We do not put the two balloons together in the mother vessel whatsoever. We put only one balloon sized 1-to-1. So for me, maybe I can do the kissing and then I would do a bot, no problem if I have a stent extending to the left main, because usually within 2 to 3 millimeters atheroma in the ostium of the LED may mandate us to make a left main LED intervention as well.
But this is a situation if we have an atheroma extending to the left main.
Yes,
but
the atheroma is not extending to the left main, but it's only 2 millimeters from the ostium of the LED. It will be dealt with also as it is involving the left main. This is the point I'm saying, because was 2 millimeters from the ostium of the left main is not a proper landing zone from the ostium of the LED from the left main will not be a very proper landing zone to make something like a precise ostial adjustment, which is actually nearly obsolete now in intervention. So most probably, as we all know, when we do an IVUS, you will have somehow this atheroma extending actually to the distal left main, and most probably it will be covered for a length of 5 to 6 millimeters, which will allow you to use a very short non-compliant balloon to make your final model.
I agree if there is an evidence of extension of the atheroma to the left main, especially by IVUS to extend this really to the back to the left main. However, there is some considerations that should be taken that we will do if the segment of the proximal LED is healthy, making our stent back to the left main make us deal with 2 bifurcation rather than a 1 bifurcation. We will do also with the LCX bifurcation. So this might lead to increase the difficulty of the procedure and may compromise the LCX if we have any lesion in the LCX. So I agree if there is an extent of the disease by the proximal LED into the distal left main. However, if we have a relatively healthy segment, should be individualized according to the coronary angiography views.
I totally agree with you. Every bifurcation is not like another, and no 2 patients are exactly the same. This is totally right.
Okay, so continue our stream with this case. So this is a 60-year-old female lady. She has diabetes mellitus on oral hypoglycemic and not hypertensive. And she presented with the infraposterior ST segment elevation of a 3-hour duration. This case was done about 4 years ago. And this is her coronary angiography where we took her to the primary PCI immediately. And this is the lesion. We have a distal left main lesion with thrombotic stenosis of the ostial LCX, with also an stenosis about 70% at the ostium of the LED. Also, we have a long lesion in the proximal and the mid LED, together with this aneurysmal dilatation, small aneurysm in this LED. And this is a better view of the LED proximal and the mid lesion, together with a significant left main, distal left main lesion. Here you can appreciate also the heaviness that present in the ostium of the LCX. And here the right coronary showed no significant lesion. So this is the rapid demonstration of the most important view of this angiography. And I'd like to ask Dr. Tamer, how would you like to deal with this bifurcation lesion?
Okay, Karim, this is an acute STEMI, okay?
Acute inferior ST segment elevation.
Acute inferior. And here is the most problematic situation. We have an ostial LCX, which is touching or encroaching on the left main. So we want to choose a technique to be suitable with an acute STEMI situation, the first. Second, we need to safeguard the ostial of the LCX. We will encroach or will go inside the left main. So Karim here, what about the decay crush?
Okay, decay crush.
I know I don't think this is, I don't prefer to go with decay crush in this situation, but about what about the use here?
In decay crush, of course, it can be used in the distal left main lesion 111 or 011, especially if we have a significant involvement of the LCX. However, I don't think we have data illustrating the efficacy of the DK crush in the acute situation or the thrombus containing lesion. And in my point of view, and I think several operators would prefer not to do a DK crush in the acute situation because of the complexity of this. The DK crush is a beautiful procedure actually, but it needs time and needs expertise and needs some patients who because we might have some technical difficulties. So I won't prefer a DK crush in a thrombus containing lesion, and this is a personal opinion, not based on robust data or clinical trial.
Okay, Karim. So I would prefer to go with a stent from the left main ostium to LECX, and I will proceed with Culotte technique. First, I will do of the. I will proceed with the stent from left main to LECX, and then I will dilate the strata of the Culotte technique. The second stent from ostial left main to LED.
Thank you, Dr. Tamer. As you remember, in the acute situation, we decided to decrease the number of balloon dilatation, and we try to put our stent from healthy to exclude the thrombus. So yeah. I felt that the Culotte technique would be good for this type of lesion because we, as you mentioned, we will put our stent from the left main into the proximal LCX. So after planning our procedure, there is I used a guiding 6 French EBU 6 French catheter with 2 wires, one in the LED and one in the LCX, and I did a balloon dilatation into the ostium of LCX with some improvement of the flow in the LCX. As I was going to continue, and I noticed the significant calcification in the LED, and I decided to do a complete revascularization for the patient. So I decided to fix the mid LED first. As you can appreciate, there is a significant calcification in the mid LED until we did a adequate pre-dilatation, and then I put a stent 3033 millimeter everolimus luting stent in the mid LED. Then a 3.5 20 millimeter everolimus luting stent in the LCX with it's some sort oversized, but there is a good flow in the LCX. And here we have a severe pinching of the LED. So we did the first rewiring. Actually, this is, as I mentioned, 3 to 4 years. So the pot here might be good to do a first pot after deployment of the every stent. And I did the rewiring and did a balloon dilatation to do a strut dilatation. This is followed by a long stent overlapped with the mid LED stent. And did the second rewiring, and I did the first balloon post dilatation for the LED stent, and did the second rewiring and the final kissing. Here, actually, as I mentioned, I didn't have a small balloon for pot, so this was the final result. Actually, this was a 3.5 millimeter balloon, so reaching a diameter about 4.6, 4.7 millimeter in the left main. And this was the final result. And the patient was, the echo, the ejection fraction was preserved after this procedure, and the patient discharged after 3 days from the CCU. So here we individualized, despite the good data on the DK crush on the distal left main, we individualized and choose to use the Culotte technique to deal with this complex bifurcation in the acute STEMI situation, because we felt that this would be easier to intervene. This would achieve a good flow, and this would achieve a good immediate angiographic outcome. And thank you so much for.
Karim, thank you very much. Very good results. Karim, if you have a short balloon and this balloon will protrude into the aorta, would you proceed with that or not?
To do that, yes, I would I should first cover the whole length of the left main back to the ostium, and I would use a balloon to a short. I would use the balloon, whatever the size, as I cover the whole length of the left main to do a final bot in the left main.
Karim, the edge of both stents proximally both are covering the ostium of left main or not?
No, they were not covering. Yeah, so I didn't use as they didn't reach the ostium of left main. I didn't use actually a small balloon, and I don't have a small balloon, and the balloon would protrude into the left main. So achieving this result, I choose to stop. However, the best practice, we should do a bot technique as a final step in the Culotte and every bifurcation.
Karim, if the left main is short, would you cover by the both stents the ostium?
If it's so short, I think yes, I think yes. Or at least one stent would cover till the ostium, and the second stent will do the adequate overlap as short as we can, which is 2 to 3 millimeters.
Would you flare up your ostial or not?
Excellent point. Till now, I still flare. Actually, I still flare. Yeah, till now, I know some operators don't recommend to do flare, but till now, I do flaring for the left main ostium.
How many millimeters you proceed inside the aorta if you want to flare is the ostial left main?
Okay, this is also a very good point. Actually, the ostium of left main is not like that. The ostium of left main is like that. Okay.
Yes.
So we should cover here and cover here. So so our stent should go to cover usually the distal lip of the left main or distal edge of the left main. So it will protrude somewhat about 2 to 3 struts about outside the upper lip. Of course, it can be like that, but it's not straight. There is a protrusion of one lip, rather, or a protrusion of one lip more than the other lip. So I should cover the most protruded lip doing the coverage of the left main.
Karim, what's your preferred view to put the ostial left main stent?
The shallow LO view, especially with some cranial angulation, this view get the better view of the best view for the left main ostium, and I'd also prefer to confirm that the ostium of the left main is coverage in the shallow REO view. So I do first the shallow LO view with some cranial angulation, and I confirm that in the shallow REO view.
Karim, if you cover the ostium of the left main and you wanted to do bot, is this a safeguard to do bot with covering the ostium or not?
If we have adequate coverage of the ostium and we choose the adequately sized bot balloon, we can safely do a bot technique starting from the distal left main up to the ostium. Remember, Dr. Tamer, we did a flaring of the ostium, Of course, we did a flare with the balloon stent or the 4O stent. However, we might need a 4.5 or 5. Usually, we need a 4.5 or 5O stent, 5O balloon to do a pot in the left main stent. So we can do it safely because we cover the whole length of the left main, and the most large diameter of the left main is the proximal part rather than the distal part.
So Karim, why from the start you didn't cover the ostium to have the land or the chance to do your pot safely?
In this case?
Yes.
In this case, yes. Back to this case, I felt that the ostium of the diagonal is, sorry, the ostium of the left main is normal, and the whole length of the left main actually is normal. So to shorten the procedure and not to take a much views, I put the stent in the left main. Actually, this is not the best point of view, and we should confirm if we choose to put our stent in the mid left main. We should confirm that we have no minor dissection by either. However, nowadays, I did this case about 4 days. Nowadays, if I fix the left main, I usually choose to cover the whole length of the left main.
I agree. Okay, thank you very much, Karim. Elegant presentation.
Thank you, Dr. Tamer, for this is a very nice discussion. And back to our moderator, Dr. Abdurrahman Tamer. So
thank you so much, Karim, for this wonderful presentation. Muhammad Adil is a very talented uprising star from Cairo University. He's a lecturer of cardiology and specialized in adult intervention. I think Dr. Muhammad Adil has a nice case to share with us. So, Muhammad, you can start sharing your case, please.
شكرا to Zahran. It's my pleasure to share my case and my experience with you tonight. Thank you, Professors Dr. Tamer and Dr. Ahmed Shawi. Here's my presentation. It's an acute coronary syndrome case. On the other side is high risk non-ST elevation, myocardial infarction in a high risk patient. I want to share this case with you and to be an interactive case-based presentation. My patient was 63 years old, male patient, hypertensive, chronic heavy smoker, morbidly obese, and have severe COPD. History of previous PCI to proximal LAD 4 years ago, presented with acute chest pain and pulmonary congestion, blood pressure on ER 105/80, pulse 55 per minute, arterial oxygen saturation was 90%, of course, positive cardiac troponin. Immediately we started to introduce giving him a loading of P2Y12 inhibitors and aspirin and IV nitroglycerin, small dose diuretics, an emergency and urgent echo was done, show preserved overall dimensions with an overall ejection fraction 45%, hypokinesia of both anterolateral and inferior wall, moderate mitral regurg, and of course ECG طبعا was done at first. Here we can see the ECG appreciate the S-segment depression in V2 and V3 and V4, 5, 6 and the severe bradycardia. Patient was really in a very critical situation. So according to the guidelines, it's a very high risk patient and should be managed as a primary PCI case or as a STEMI for a primary PCI like stretch. After initial stabilization, we went directly to cath lab. We choose a radial approach, of course, because it's preferred in acute coronary syndrome. And this patient particularly, he was severely obese, morbidly obese, and and congested and orthopnic. So by all means, we have to choose radial approach. This started with the right coronary. You can appreciate here is no significant stenosis as a dominant vessel with evidence of retrograde filling of LED and circumflex. Here we can appreciate here this ugly anatomy. Here a large circumflex giving actually it could be a codominant vessel giving posterolateral branches, and here we have a very tight lesion in the proximal circumflex. Also, the LED show a proximal beta stent followed by subtotal occlusion. So we have this high-risk anatomy. Further views. This is the epicranial view. We can appreciate the tight lesion in the LED. Actually, it is a long lesion following the stent and involving diagonal. And of course, the acute occlusion of the circumflex. طيب, in your opinion, يعني, what is the best management? Should I send this patient for cabbage or to نستخدم thrombus aspiration catheter or urgent ad hoc PCI with bailout use of 2B3A inhibitors? What do you think? Hello?
محمد طبعا هو
مش واضح ولا ايه؟
لا واضح يا محمد.
كويس.
هو hard situation طبعا. Situation of non-STEMI, بس we would like to deal with as a STEMI. We have a thrombus burden, high thrombus burden. We have an left complex with a proximal lesion. Then there's an aneurysm, I think this is in the proximal part, followed by a tight lesion, and we don't see well what about the OM branch. So this is the first. Second, in the LED, there is a total occlusion or significant lesion in the mid LED, which have a retrograde flow from the right coronary. The right coronary, I think, there's a proximal non-significant lesion. So the situation here, would we proceed as a primary to go to the LCX only with OM, or we would proceed for a complete revascularization, in your opinion?
هو انا في الموقف دوت لو حد عايز يشاركنا رايه برضو، يعني قبل ما اقول انا رايي، يعني برضو الواحد بيبقى محكوم.
محمد, if you please can we speak in English because we have
okay. In this situation we have to choose the decision according also to the regulations and availability. This patient is a high risk for surgery. He's already in impending pulmonary edema, active troponin, and surgery will be يعني very quickly. Actually, the patient also has ongoing ischemia, is an ongoing chest pain, not improving at all on nitrates or antiplatelets or anticoagulations. My point, يعني I started with wiring of both lesions, LED and complex.
May I have a comment, please?
Yes, sir.
Yes.
First, thank you, Muhammad Adil, for presenting such an interesting case. You have a very good clinical approach to the patient with excellent risk stratification for such a patient. Actually, the guidelines may favor the PCI to this patient. I'm not talking about the anatomy or the syntax score now, but the clinical situation. We have a non-STEMI risk stratified as a very high risk and acute heart failure or impending pulmonary edema. So the guidelines may favor the PCR.
Yes.
Regarding the coronary angiography also, we can appreciate or determine the culprit because we have a thrombotic occlusion of the LCX. So I think we have a clear culprit, although determining the culprit in non-STEMI cases may be somehow difficult.
Okay. And my point when I took this spider view, shall I put just one stent in this thrombotic lesion in the circumflex in the mid segment, and to deal later on with this left main by another stent, or I can take just one stent to cover from the ostium to this side. So
Muhammad, you will proceed by putting two wires, one in the left circumflex to OM, I think, and the second in the LED. Then you will proceed by balloon dilatation,
yes,
and you will re-evaluate to take your final decision.
أنا عملت كده. Yes, that's actually what I did. After wiring both vessels, and I did pre-dilatation by combined balloon to by 20 millimeter. I decided, but I don't have this video. I decided the flow in the left circumflex improved markedly. So I went quickly to LED and fixed it by two overlapping stents, 2.75 by 42 and 3.5.
Muhammad, please, we don't have the video of the left circumflex.
Yes.
Okay.
Yes.
After you make a dilatation of the left circumflex or circumflex torque to OM branch, what
Yes.
about the caliber of the distal part of the segment of the proximal LCX?
Can appreciate here. This is the results after redilatation of the subtotal occlusion of the proximal circumflex, not the ostium, just at the site of total occlusion. I guess flow improved markedly and the patient a little bit becomes stabilized. So I went to...
You have, yeah. Muhammad, you have a thrombotic lesion in the left circumflex, okay?
Yeah, yes.
You did a balloon dilatation of the circumflex and get
Yes.
a Temisin flow as I see, okay?
Yes.
Then
what about... Yes.
Yes, what about the lesion after balloon dilatation in the mid circumflex? It
Yes.
looks to be significant.
Yes, yes, but I went first to stent or to open the subtotal occlusion in the LED. Then I dealt with the left main, distal left main as a Culotte technique. So I did.
So you have the decision
after stabilization flow in the circumflex. Yes, I went to open the subtotal occlusion in the LED.
Okay, Mohammed. So you have the decision now that you will go by Culotte technique for this bifurcation lesion. Okay.
Yes.
So you go first to treat the mid LED, then to proceed with a bifurcation lesion between left main to left circumflex and left main to LED.
Yes.
Okay. This is your strategy after you have a good flow in the left circumflex.
So actually, this. Okay. After I stabilized flow in the circumflex and the patient get improved, I went to mid LED to put my stents. I afraid actually after if I started with the left main and leaving this LED with subtotal occlusion, it's a large vessel. Patient we cannot put, I have to stabilize flow in the LED first, then I will go to left main. Particularly the left main LED is not that tight. and the flow is, if I stabilized the mid LED, I can deal with the left main at a slower pace, and I can do a good job with good flow.
Mohammed, if I go back to the ACG, we have ST segment depression from V2 to V6, I think.
Yes.
Is okay? So the predictor here is that the LED is a culprit, not the left circumflex.
But
Even you have
a
different. Oh. Yes. So it is reasonable to go also for stenting the LED and to do completive vascularization.
Yes, that's what I did.
Yes.
But in your opinion, what is the best management? There is a clear landing zone, so I vote for a provisional one-stent strategy covering the osteal LCX. Is it true distal left main lesion? I prefer to strategy. Significance of the osteal LED is not clear, so I need more views. Actually, in this view, I can, at this point, I couldn't appreciate as there is a main LED. So, should I put just a stent covering the ostium and this tight lesion circumflex? Actually, I don't have IVUS at this time, but when I took further views, we can appreciate here there is a left main disease. It's clear, and here there is significant involvement also in the proximal LED. So I decided to deal with two-stent strategy involving the distal left main.
Mohammed, I wanted to stop here for a moment, please. Mohammed, before going to what type of technique we will choose, if we don't have an IVUS, and this situation present in many cath labs, and we have a true osteal LCX lesion, could we consider that as a left main lesion or not?
Isolated LCX lesion significant could be present. This and on the other side, left main, the true osteal LED is usually associated with left main involvement, but osteal circuit could be an isolated fibrotic ring or something like this. But in this situation, more views and more cranial angulations could elaborate that the involvement of both LED and circumflex.
Okay, proceed, Mohammed.
Right. In your opinion, which strategy should we choose? Dicky crush, or tap, or mini crush, or Culotte technique? Patient is high risk and is congested. I should choose a strategy that make me deal with left circumflex first, because the plaque burden and the thrombotic burden is more on the side branch of the circumflex. So I choose the Culotte technique. Particularly, the size of both LED and the circumflex were also comparable to each other, and the left main was short. So I decided to choose Culotte technique. I did this case through a radial approach using 6 French guiding caster. So I need techniques that can be sequential. I feared the guiding caster couldn't accommodate 2 stents simultaneously, or large stent and a balloon for crushing if I did a Dicky crush. So a Culotte technique, I think, was best for this, in my opinion, at this time. I started with stenting.
Mohammed, please. Mohammed,
yes.
You have a proper technique here, because you will guard the left circumflex and left mean. You have to see in the other projections that left mean is affected. And if you put your stent from the osti left mean to covering whole the lesion in the left circumflex, I think you will guard yourself and you will go to proceed with more comfortably. Okay, so I think this is the proper technique here, because you secure yourself, you secure a big artery or big vessel, and you have a good land to put your stent from the left main to left circumflex to proceed for the other steps safely.
Yes. This was a stent 4 millimeter diameter by 38 length.
What's the size of diameter?
Stent deployment 4 millimeters here.
4 millimeter, yes.
Stent 4. Stent deployment 12 atmosphere and post dilatation with at 16 atmosphere.
Mohammed, please, what's the length of the stent? The length of the stent.
Yes.
38?
And this is the final after what? This is the
Please,
final
Mohammed, what is,
control.
I ask about what is the length of your stent?
38 millimeters here.
38, yes. 38
yes.
4 by 4. Yes.
Yes. 4 by 38.
Yes, okay.
4 by 38 Ultimaster stent, sirolimus drug eluting stent. I put it covering the whole lesion in the circumflex and extending into the left main, but not reaching the ostium of the left main. Here's after deployment and proper post dilatation of the stent. I make sure that there is no edge dissection and my stent is well opposed and no other complication. So I did my first wire exchange wire in the LED was reintroduced again through the struts of the left main circumflex stent. Then I dilated the left main LED through LSX stent struts by short balloon. Then I put the left main LED stent 4 by 28 millimeter with taking this view LO cranial to make sure that I am covering the ostium of the left main. And here is the deployment of the left main LED stent. Then the second wire exchange, but we should make sure, we be very cautious that the LCX wire became jailed, and when we retrieve the wire, the guiding may injure the left main stent. So we have to disengage the XB guiding caster and to exchange the wire carefully to avoid the crushing of the left main LED stents. Then I did a kissing balloon using two 3.5 millimeter non-compliant balloons. And final proximal left main using 4.5 by 12 millimeter non-compliant balloon. And this is my final results. This case, actually, I did it last summer, and the patient is doing fine on follow-up and is compliant with medications. My take-home message in this case, we highlight the importance of the guideline-based management. Primary PCI-like strategy is recommended for very high-risk non-STEMI cases. Radial approach is recommended, although it is challenging, particularly in distal left main intervention. Glycoprotein to B3 inhibitors as a bailout therapy during PCI is helpful. The prevalence of significant multivessel disease in non-STEMI patient is high, and defining the culprit lesion is usually challenging. PCI is reasonable in non-diabetic patients with left main stenosis involving the distal bifurcation with less complex coexisting multivessel disease as defined by low or intermediate syntax score. Evaluation of left main disease's significance is highly challenging and require assessment of different perpendicular angiographic views. IVAS, of course, should be much helpful for sizing and optimization. However, it was not feasible in this urgent high-risk situation. The choice of left main intervention technique depend on different factors and geographic findings like diameter of the two branches, bifurcation angles, severity of the osteocyte branch stenosis, extent of the main vessel disease, the equipment's availability, and the operator familiarity with the technique. Final plot is highly recommended in bifurcational intervention to reduce the risk of strut malapposition in the main vessel, optimize the final stent geometry and flow dynamics, open stent cells overlying the side branch ostia. Thank you.
Thank you very much, Mohammed. Very elegant presentation, very good results. Mohammed, you do only one pot in your case, okay?
Yes. Actually, after the deployment of the left main LCX, I did a good post dilatation, but not typical pot, because I want to reduce the steps a little bit because the patient was in risk situation, and when I was sure that stent was well posed and well deployed, so I start to re-exchange the wire and to complete the procedure. After deployment of the
Mohammed, I have a short message that we are in the acute situations. Sometimes we don't need to stick to all the steps of the technique, especially if we have a good signs of success. It is proper to do with 3 pots. It's okay, but I have an emergency or an acute setting. So sometimes we can proceed with 1 pot is okay because the final result is satisfied. We don't have any defect, we don't have any malapposition. So we have a final good results. So sometimes we, in the acute setting, we have to change our minds, we have to change our strategy according to the situation we have. Do you agree?
Yes, yes.
Okay.
I think the most challenging point in this situation that I decided to just open the culprit vessel by a balloon, and when the flow improved, I decided to open the LED. I have 2 main vessels which are actually totally occluded, so I started to open by PTCA the circumflex. Then I shifted to LED to open the mid LED. Then I assessed again the left main. Then I started to do a distal left main bifurcation, and that I chose.
Mohammed, had you used to go with glycoprotein to B3A like in this case? Have you used
actually I used this. I used tirofiban in this case.
The question, why?
Why?
We have chemistry flow. We don't have a residual thrombus. So why you choose? You have chosen that.
Actually, and the flow in the circumflex improved not just after balloon dilatation, also after giving a bolus of tirofiban.
So you give an intracoronary or intravenous tirofiban?
Yes, intracoronary.
Intracoronary.
Yes.
So after you finish your case with chemistry flow with no residual thrombus, should you continue with tirofiban, or is that enough? You have a good flow.
Because actually in this case I continued in tirofiban, but because I put about 4 stents in this case, and he has already 1 previously deployed. This has heavy metal burden and thrombus burden in acute setting, and the ejection fraction is impaired. So I prefer to continue tirofiban for just for 12 hours. Then I discontinued it.
Mohammed, I wanted to give a short message. What is meant by bailout to the audience? What is meant by bailout glycoprotein to BCE?
Bailout that it is now obsolete and is not recommended to start glycoprotein to B3 inhibitor from the start or upstream.
As a routine. As a routine.
Yes, at the beginning. In the last years, many years before, can the operator told you send the patient and start even glycoprotein, even doing a coronary angiography. This is now completely obsolete. I have to do a coronary angiography and assess the thrombus burden, and after initial balloon dilatation, if the flow improved and no problem, and you may not use this glycoprotein to B3 inhibitors. I think this is because we now have strong antiplatelets like P2Y12 inhibitors, clopidogrel, and the more potent and recommended is ticagrelor, which is more potent. So no need for routine use of glycoprotein to B3 inhibitors. Particularly, most patients with acute Crohn's syndrome are elderly and bleeding risk will be high.
Mohammed, I have a question. If in your case you didn't have a flow in the lesser complex, what strategy will you go? You try to dilate, but you don't have a flow.
I would put a stent in the circumflex, but it may be a short stent, just as a site of the total occlusion, but also without touching the left main, because
Mohammed, I ask you about, I tried to inflate the balloon, but I did not get a flow. So what will you do?
I didn't get a flow at all.
Yeah.
Okay. Many things. Just I can try larger balloon if the balloon size, if I choose, is actually small. I can give glycoprotein to B3 inhibitors. First, I should also make sure that my wire is in true lumen and no problem in wiring.
Would you proceed by aspiration, Mohammed, if you have no TIMI flow, TIMI zero?
If all these attempts failed, of course I will use aspiration caster if it is available. It's actually now it may be used as a bail-out therapy as glycoprotein to B3 inhibitor in high or large thrombus burden, TIMI flow 0 or 1, after failure of other alternative techniques.
Mohammed, I want to ask about the opinion. If you have TIMI 0 flow, it should.
الصوت مش واضح. Hello?
Mohammed, what about the opinion? If you have TIMI 0 flow, you shouldn't use a glycoprotein to BCA. Is that right or not? Do you agree or not? If you have TIMI 0 flow, would you proceed to go with an intravenous glycoprotein to B3A infusion or not?
Intravenous or intracoronary?
Whatever, intravenous, intracoronary. You have TIMI 0 flow. Would you inject?
I think Dr. Mohammed, I think we should have just at least TIMI 1 flow to have effective at least TIMI 1 flow to have effective usage of the glycoprotein to B3 inhibitor, because if we give with the TIMI 0 flow, this won't achieve any benefit. I think so.
I think there's a tip here, and can use a balloon with we made some fenestrations and inject a glycoprotein distally, or using a microcaster, or using even the aspiration caster to inject glycoprotein distally. But if we don't have zero, if TIMI flow 0, I guess intravenous injection will not get benefit as Dr. Karim said.
So, Mohammed, we will try to get any type of flow. Then we can proceed with many options. It's okay?
Yes.
Okay. Abdurrahman, you have any comment?
Thank you, dear Professor. Actually, Muhammad Adil and also Karim Mahmoud give us two marvelous cases. Both of them start with the side branch. I would like to ask you, dear Professor Dr. Tamer, and also Dr. Ahmed Shawi, dear Professor Dr. Ahmed Shawi, about your opinion to start with the main branch or the side branch in Culotte technique. I know in bailout, of course, we start with the main branch because we do the side branch as a bailout. But if we are planning for two-strand technique from the start, from your experience, do we have evidence or just experience for starting with the side branch or the main branch? I want to know your experience.
Abdurrahman, in the previous two cases, the culprit lesion mostly was the branch. Okay, if we consider that LED is the main and the LSX is the branch, the post of previous cases, the culprit lesion was the left circumflex. So to secure your first stent from the left main to the circumflex is the most important default one. I have secured the culprit lesion. I have secured the main lesion in my case. Then I proceed to the other branch. Okay, but sometimes there's a school to secure first from left main to LED. This is a school for some interventionist. I don't agree. And this is a debatable issue between me and many other professors in the discussion. I think that to go for the branch first and to go easily from the strata of this branch to the more straight vessels with a secured wire, this is the most important one, because sometimes you make the procedure more difficult for you when you are practicing. This is an important issue for the interventionist. You should make it more easier for you. Don't complicate your case. Don't complicate your strategy. Make it less easier to do. This is a very important issue, Abdurrahman. So it is first to go from left main to circumflex, which is a branch, secure the culprit vessel, and you can proceed more easily, more comfortable in your case. Sometimes we need another, but this is the most default technique for me. Sometimes we need to do the reverse.
الصوت مش سامعين حضرتك.
I would like to add, if I'm Ahmed Shawi, and again, I want to thank you for the lovely cases and the lovely presentation. It was a great webinar so far. Very good question about which to start off with. In the classic culotte, you start off with the side branch in most cases. Yes, I agree. But again, when would you use to start off with the big main branch? Actually, if this main branch has more disease, if this main branch has more affection of the lesion, you might think of it. But an important part to take in consideration, and this was a problem in the beginning of left main intervention, is that we had stents that their side holes will not open up to very big vessels. If you had a 4.0 circumflex, the cipher stent was not equipped for this 4.0 side branch. So in culotte, in bifurcation techniques overall, just check your equipment and make sure that your equipment is safe to use. Again, I think a pot is very important in culotte because you have two layers of metal, and here a pot is really important, especially if you're talking about a left main culotte.
Thank you, dear professors, Dr. Ahmed Shawi and Dr. Tamer Mustafa. I don't know if my dear friends Karim or Zahran or Ahmed or Professor Hatim is also with us. Have any comments or questions for our dear professors, Dr. Tamer and Dr. Shawi?
Abdurrahman, I would thank all who shared this meeting. Thank you to Karim and Mohammed for highly illustrative cases. They introduced a well-stepped procedures for these critical cases, and both were acute settings. And this is very important to deal with the acute setting, stepwise approach. So this is a very good learning issues. informative cases, and clear technique to do. Thank you very much for this highly elegant professors and highly presented lectures today.
I'd like to thank you, Dr. Tamer, for your excellent moderation today. We have enjoyed your moderation for this webinar a lot, and your insights into this webinar were marvelous, actually. Thank you so much.
Thank you very much, Karim.
Okay, I think we have come to the end of our webinar. I really want to thank our dear professors who elegantly moderated the webinar today. Professor Dr. Tamer Mustafa, Professor of Cardiology at Zagazig University, and Professor Dr. Ahmed Shawqi, Professor of Cardiology at Ain Shams University. Actually, this course is truly successful because we have an eminent professors like you who could take these webinars to a very, very high level of science. I would like also to thank Muhammad Adil, our dear friend, and Karim Mahmoud, of course. Actually, I would like also to thank all the CEC board, Professor Dr. Muhammad Zahran, Dr. Haitham Suleiman, Dr. Karim Mahmoud, Dr. Ahmed Saeed. They spent a lot of their time actually trying to give these courses and activities the best of their times. Inshallah, next week we will have another level of this course. We almost achieved half of the course. The second half will be more advanced. We'll talk about the bifurcation in left main the next week, and then CTO with bifurcation, then 9 layers in bifurcation, and the trifurcation will be the last webinar through this course. Please be always with us. Next Thursday, we'll continue our clinical cardiology webinars. We'll continue with valvular webinars. Also, the next Saturday, we'll continue the congenital heart disease webinars. Thank you all, my dear professors.